I'd like to welcome Dr. Bruce Patterson to Texas Lyme Alliance's event on chronic inflammation. Dr. Patterson is the CEO and founder of Incelldx, a virologist, a pathologist, and was former medical director of diagnostic virology at Stanford University Hospitals and Clinics. Dr. Patterson and his Chronic COVID Treatment Center is combating inflammation in many patients like the Lyme disease community experiences. He was also at the forefront of the HIV epidemic and applied his therapies to other communities such as the chronic COVID community, as well as post-vax COVID and fibromyalgia and ME/CFS. We welcome Dr. Patterson and thank him for coming to our event today.
These are enormous numbers of people who are walking around with chronic inflammation, and we're seeing all of them now. And really, thanks to long COVID, we're starting to see these individuals with chronic inflammation. However, not everybody who has fatigue, post-exertional malaise, and brain fog and has had COVID has long COVID. And I think, this is not to detract from all the individuals who are suffering from long COVID, but what it's doing is the COVID pandemic is really exposing the Lyme pandemic that has gone very unrecognized to date. The other thing that we discovered along the way a couple years ago was that vascular inflammation is a common underlying pathology for all these chronic conditions. So I'm going to be talking about two things today. One is how similar diagnostically all these conditions are, and what how similar the pathology is and how similar the treatment can be, but how different they are from a diagnostic standpoint, which allows us to be essentially the only group in the world that can tell the difference between all of these inflammatory conditions. My big fear as I, watch other groups publish is how did they diagnose long COVID in that long COVID paper? That's the first question anybody has to ask. Because if they're just going on symptoms and the fact that you have symptoms 3 months post-infection, you're not even close to the actual diagnosis. So studies that make comparisons and make conclusions without really defining what they're looking at can be misleading. Because what happens in acute COVID that most people don't realize is that these patients are supremely immunosuppressed. We published this way back in March of 2020, this paper on acute COVID and treating acute COVID with CCR5 antagonists. And what we found in the lower left-hand corner is that patients with acute COVID had CD8 percentages, some in the single digits, but certainly below 20 and in the teens, when normal is 30% of your T lymphocytes. Now, not only was there a numerical lack of CD8s, those CD8 T cells were immune exhausted, meaning they've been exposed to antigen for an extended period of time and started not working. The other thing we discovered in this paper was that that the CD8 T cells produced less of a compound called granzyme A, which is almost like a bullet in a gun, is how CD8 T cells destroy virally infected cells, intracellular bacterial infected cells, and cancer cells. So this immunodeficiency caused by acute COVID leads to reactivation of the chronic herpes viruses, which have been highly implicated in ME/CFS, can cause replication of inadequately treated Lyme, and then those bugs come out and start replicating and cause symptoms. So the reality is it's this immunosuppression that leads to an exacerbation of ME/CFS and Lyme, and those symptoms appear right around the same time frame as long COVID, which is 2 to 3 months following a reactivation event. So to say that you really know who has long COVID by looking at symptoms, like I said, is very misleading. And as you can see here, if you look at the symptoms that we first published in long COVID, and again, there's probably 200 that people have reported, but fatigue, brain fog, shortness of breath, post-exertional malaise, joint and muscle pain are quite common in long COVID. And if you overlay the primary symptoms of Lyme, fatigue, brain fog, joint and muscle pain, insomnia, it's almost identical, as is if I overlaid this chart with ME/CFS. Now we have a study that's pending and undergoing peer review, where we show that post-vaccination individuals with long COVID symptoms in the absence of being infected by COVID have brain fog, fatigue, neuropathy, joint and muscle aches. Very, very similar once again, and it's common in just about all of the different vaccine types. So we're dealing with these enormous cohort of patients that all present mostly with fatigue, brain fog, and the inability to have any kind of activity. So we really launched the first long COVID diagnostic last September when we achieved CE-IVD regulatory approval in Europe. We've since submitted all our data to the FDA in the United States, and we have several reference labs who have validated this test under the CLIA rules and are offering this to patients throughout the United States. And the first question was, when we launched this test, well, how do you interpret it? And, our first response, well, in the Chronic COVID Treatment Center, we'll take this data and we'll put it through our algorithms, which we still do. However, in submitting our data to the FDA, we were very careful and looked at several different algorithms, including one that is solely based on what we call the long hauler index, or LHI, which I'll show you in a minute, which makes interpretation of the results so much easier, not only for the Chronic COVID Treatment Center and the 9 physicians that we employ, but also for all the general physicians out there and physicians who are treating ME/CFS, Lyme, etc. Again, through a deal with SynLab, which is one of the biggest laboratories in Europe, reference laboratories, they cover all the countries you see on the left, including Brazil, Latin America, etc. And we just announced through a press release a couple days ago that we signed a deal with Helios in Australia and Southeast Asia to bring the test to that region of the world. So we're really global right now, in addition to having obviously access to this test in the United States. And we're trying to spread the word about how to interpret the test so that the general practitioners and the PCPs can understand how to use it. But most importantly, how did we determine that this was a long COVID diagnostic? Well, our bioinformatics guys, using machine learning and AI, developed 2 algorithms. On the horizontal axis is the long hauler index, which is interferon gamma plus interleukin 2 divided by CCL4. And on the vertical axis is the severity score, which we used for acute COVID. And now we've integrated into some of our algorithms to distinguish between Lyme, ME/CFS, and long COVID. And you can see in yellow all the patients who have long COVID. In red are the patients that have post-vaccination long hauler symptoms. And in blue are the patients that have ME/CFS. I think you can see from this visual, what I'll be telling you in a moment, is that they have similar aspects and they have differences, and we can take advantage of the differences diagnostically to discriminate between all of those different classes. And that's what we just submitted to the FDA, and it's going to be the basis of a new paper. And that is, we have the ability over on the left table to distinguish PASC from a group called not perturbed. Well, what's not perturbed? That's a great question. Well, it's a composite of healthy controls and patients with mild to moderate acute COVID. In other words, we have the ability during the pandemic or during the fact that we still have many, many acute COVID cases. And frankly, right now I'm surrounded by about 8 people who have acute COVID. So it's not going away anytime soon. We're just not thinking about it as much. But the fact is, we needed a diagnostic that wouldn't be affected with either false positives or false negatives by somebody who may have subclinical or very mild acute COVID. And that's what we achieved here. We were able to have 97% sensitivity and 100% specificity for long COVID compared to normals in patients with mild to moderate acute COVID. So then we went on to ask the question, well, what if we are looking at a population that may contain ME/CFS or chronic fatigue, Lyme, long COVID, and post-vaccination long haulers. And we developed algorithms that allowed us to still maintain high sensitivity and very high specificity for all these conditions when they're mixed together. So that's our ability to discriminate between these chronic inflammatory conditions. And the fact is, look at the results with Lyme. If we had no long COVID, we would be out talking about this new approach to screening for Lyme disease. And again, we're not looking for individual organisms like Borrelia, Bartonella, Babesia, etc. But we're saying this looks like post-treatment Lyme disease. And I'll show you exactly how we do that. And that's here. We've really never talked about this much because this is behind the scenes. The raw data from the reports that you may receive from Radiance and soon to be from IGeneX really shows how we decide what chronic inflammatory condition you have based on non-subjective means and not based on patient history. You may come in and say, oh, I have long COVID. And this is going to be built directly into the laboratory information system so that it'll generate a report that says you have an 88% probability of having long COVID, you have a 9% probability of having Lyme, you have a 2% probability of having ME/CFS, and that is going to be an incredible tool for the clinicians because they're all treated differently. So I'll get into that in a moment, but the long and short of it is if they have Lyme and what we'll talk about next, which is vascular inflammation, we may add antibiotics or Bartonella therapy to how we're treating vascular inflammation. If it's ME/CFS, we may add an anti-herpes viral medication in addition to treating the immune system. But the bottom line is we've developed these algorithms to tell the difference. And what have they generated? Well, this is what's so exciting. And just last week in 2 days of telemedicine, I probably picked up 6 people who had Lyme that was later confirmed by Lyme testing using these algorithms who didn't know they had Lyme. So, we're starting to identify all the people who are walking around out there who don't feel good. They have fatigue that they can't get over. People have called them ME/CFS or chronic fatigue because it's really a diagnosis of exclusion. Hey, if you're fatigued, we can't find anything else, you have ME/CFS. Well, you know what? They may have Lyme. And so what we look for is in our 14 marker panel is elevation of interleukin-8 plus interferon gamma can be Lyme. Interleukin-13 plus interferon gamma can be Lyme, and a long hauler index greater than 7.1 can be Lyme. And as I showed you, using this in our algorithms, we have been spot on with almost 100% sensitivity and almost 100% specificity in detecting Lyme in a mixed population of Lyme, long COVID, ME/CFS, fibromyalgia, and others. The other one thing that we do caution is if there's elevations at interleukin-8, that is the key. Interleukin-8 is the key differentiator from someone who has long COVID and from the virus and someone who has long COVID symptoms potentially from the vaccine. The big differentiator is, of course, interferon, which has always been known to be elevated in Lyme disease. What else are we looking for? Well, as part of our cheat sheet, we are looking for this triad of markers, SCD40L elevation, CCL5 or RANTES elevation, and VEGF elevation, which is the triad of vascular inflammation or endotheliitis, as I'll show in a moment. 2 out of 3 of these, and we're almost guaranteed that vascular inflammation is at play. We verify that when we talk to patients and confirm that they have hot-cold insensitivity, they're cold all the time, they're fatigued, post-exertional malaise, etc. Those are hallmarks of the elevation of these biomarkers in vascular inflammation. So while long COVID, Lyme, and other inflammatory diseases are difficult to diagnose because of overlapping symptoms, understanding these immunologic mechanisms has really been the key to effective treatment, as I'll show in a minute. Now, our hypothesis is, like we discovered in long COVID, where the SARS-CoV-2 S1 protein persists in long-lived monocytic subsets. Similarly, the peptidoglycan cell wall of Borrelia is not only persists, but may be disseminated by monocyte subsets similar to the mechanisms we discovered in long COVID. And the thing to remember is these monocyte subsets are really long-lived. And people, always say on social media or something, well, when they looked it up, they live for a week or 10 days. Well, that's in normal people. When they're presenting antigen, it short circuits their apoptosis pathway, which is the pathway that causes cell death. And they live for long periods of time, months, years, maybe even decades in post-treatment Lyme disease. And these cells cross the blood-brain barrier. They cause vascular inflammation both in the periphery and in the brain, and they cause all the symptoms that many of you are suffering from. This is how we detect it. We're coming up with a Lyme diagnostic that's very similar for the Borrelia cell wall, where in blue, these are non-classical monocytes, and in this box, these are S1 positive non-classical monocytes. In the middle are intermediate monocytes. They also carry S1 protein, and very little, if any, in classical monocytes. And this is our immunoquant S1 assay that's available at Radiance now and soon to be in SynLab in Europe and around the world, and now in IGeneX in California. And what is it about these non-classical monocytes that leads to vascular inflammation? Well, non-classical monocytes bind to endothelial cells, or the lining of blood vessels, through a protein called fractalkine. These monocytes express the fractalkine receptor, and of course bind to the blood vessels, are internalized into the blood vessels, and cause inflammation. And that inflammation, as you can see down in the middle, consists of what's called a Th1 response. Well, Th1 cytokines are interferon gamma, interleukin-2, for instance, which happen to be the numerator of our long hauler index, which was developed using machine learning and AI. Machine learning and AI was unaware that this paper showing what I show in this slide was published in 2004. So fascinating how effective machine learning is when it can actually look at data and pull out something that is related to a particular disease, and then you go back and search the literature, and in fact, it aligns with what's been published even 2 decades ago. Here's another graph which shows on the far left a monocyte binding to fractalkine. Well, what does that do downstream in the endothelial cell? Well, it causes angiogenesis, which is driven by the overexpression of VEGF, and it causes vasodilatation, which creates the head fullness, headaches, migraines, POTS, and brain fog that you see in long COVID, Lyme, and ME/CFS. The reason for vasodilatation doing that is that when the blood vessels dilate, you have more blood to your periphery, you have increased blood flow to your brain, and you get hot-cold insensitivity, so poor temperature regulation when your blood vessels are inflamed. You have headaches and migraines because, of course, they're caused by dilated blood vessels, not by constricted blood vessels, as a lot of us tend to think. And POTS, which is nothing more than dilated blood vessels transiently dropping your blood pressure, and then a drop in blood pressure leads to compensatory increases in heart rate. So POTS is not something inherently wrong with your heart. It's just doing exactly what it should be doing, and it's doing it in the face of inflammation. Yet every physician you go to loves to say that people with chronic inflammation have POTS, as if it's something unique and something unsuspected. But in fact, because of the vasodilatation, it's very much expected. So we can take some of the mystery behind POTS out of the equation. So how do we treat this thing? Well, the key really is to focus on the immunologic mechanisms of inflammation and define the pathways involved, and then use drugs that actually address and target those pathways. So in fact, infections typically lead to inflammation, and that includes COVID. Inflammation leads to symptoms, as I'll show you in a moment. And the key is we're the only group that's actually showed that if you decrease inflammation with targeted drugs, you decrease symptoms. So we've closed this loop. And I would say that all the people publishing about autoantibodies need to close this loop. There's a lot of reports out there saying this autoantibody related to this, or this marker related to X, Y, or Z. But what they really need to show is that when I bring that marker down, these symptoms X, Y, Z go down. And that's exactly what we did in this trial, or in this paper, which was published 2 months ago, where we actually looked at symptom scores, Rankin, which is neuro, Compass 31, which is dysautonomia, NYHA, which is cardiac, shortness of breath, but most importantly, the fatigue score and fatigue score severity, we found has a very strong correlation with expression of TNF-alpha and interleukin-2 with very low statistically significant p-values. We are very surprised in this paper when we used maraviroc and pravastatin that we were expecting the fatigue score to go down in these individuals, but all 5 of these symptom scores went down in a 6 to 12 week period. And that is leading to Incelldx's randomized clinical trial. We just are about to present or submit our trial design to the FDA. It will be a phase 3, and we're looking at somewhere around 500 patients. It won't be very long trial because it is a phase 3 trial, solely looking for efficacy. And then once we complete this trial, the plan is to move on to Lyme, because really these two drugs target that fractalkine driven vascular inflammation pathway, which is common to all four of those inflammatory conditions: long COVID, Lyme, ME/CFS, fibromyalgia, and post-vaccination long haulers. So again, in this paper published 2 months ago, we showed statistically significant decreases in SCD40L, which is the first protein made in the thrombotic cascade in the blood vessels. Interleukin-2 came down statistically significantly, as did CCL5 or RANTES, TNF-alpha, the leading cause of fatigue, and VEGF. All those markers came down in this 20-patient study that was published 2 months ago. And then, like I said, all the symptoms scores came down before and after treatment. All of them were statistically significant decreases in the symptom scores. So that really led us to this study, where we extended those 20 patients to 314 patients pre and post Maraviroc and Prevestatin. And again, the numbers and p-values held up, where we saw, for instance, with the long hauler index, 4 times 10 to the minus 6 p-value. What does that mean? It means that 4 in a million chance of this decrease being caused by chance. So these data are very real. The FDA guidelines for approval is 5 times 10 to the minus 2, which is 5 chances in 100 would get approval, and we're at 4 chances in a million that this data could be by chance. So in summary, monocytes and CCL5 RANTES appear to be a common link in post-infectious conditions that drive chronic inflammation. This new analytical approach using immune biomarkers can allow us to identify and diagnose diseases such as post-Lyme, ME/CFS, and others, and guide us into how to treat them. And we're pioneering a new way to manage patients suffering from chronic inflammation using a robust symptom tracking system combined with our novel machine learning driven diagnostics to really look at non-subjectively what patients are going through. And that's the advantage that we have.